Wednesday, everyone. So this afternoon, I just really wanted to open it up for committee discussion. We've heard an awful lot on con. I'm trying to change my how I refer to it.
Like CON better.
Me too, con sounds
It
negative.
sounds anti. All right, well, let's not discuss that. Just saying.
That's part of the discussion.
You brought it up. We've heard a lot of things. We've heard a lot of things from different parties, interested parties, a lot of information to take in, some things that we might want to add or not add. Some things we may want to tweak or not tweak. And just wanted to get a committee discussion going around what your thoughts were. I think the plan is right now, and I think it might be on our agenda for next week, that we will have committee discussion today. Anything that we may want to change, that will give our legislative council plenty of time to work on things. And we happen to be having Green Mountain Care Board in next week for a couple things. I think budget on Thursday. And I was sort of hoping that during that time, we could go over with them the changes we've made and get their comments on that. And we would, at that point, do markup and possible vote. If people feel like they even want to proceed with it. So anyways, this is committee discussion. Anybody, Brian, would you like to start?
Well, I've been in and out of the room, so if I miss something, I want to ask people to have some grace with me, because sometimes I do miss pieces because of whatever, but my opinion so far, unless I miss something, is this would reduce regulatory barriers that might save the system of care some money. And there's still plenty of regulatory barriers that a facility has to face. Like, this is just one, that we're not even talking about Act 250 and permitting and like local regulations. So unless I'm missing something, I feel like reducing this barrier slightly isn't even gonna address all that other stuff. In fact, we might want to, if we really want to address the barriers, talk with people during the process of land use planning about how do we look at the placement of medical facilities in housing developments. Like, imagine if, as we build housing developments, we're building clinics in the housing developments, or like gyms and facilities for people to engage in healthy behaviors, or, so there's a way. I think this is a step in the right direction, but I think if the intent is to reduce regulatory barriers, to reduce the cost of healthcare and improve population health, there's way more we could be doing than the certificate of need. That's my kind of opinion so far. I'd like to hear what Green Mountain Care Board has to say too. So that's my opening thing. And so if I miss something, if somebody says, no, this person said this, then I will apologize for missing it.
Maybe our legislative council can remind us, because I don't think it's in the bill, it's probably in the little ellipses somewhere. What is currently exempt completely from the CON process? So this will give us an idea of, as what is already exempt, so that we're not talking about, we're not inflating in our heads what the CON process currently entails with particular facilities or practices or whatever that don't even require CON anyways.
Could we actually start with, back further with Alan's question about why CON,
Yes.
how did it happen?
Yes, thank you for reminding me. So let's start at the very beginning.
Jen Carby, Office of Legislative Counsel. So what I can show you, I was not here when this first started, but I can show you what is in the statute around the policy and purpose. Okay, so this is in Title 18 in the chapter on healthcare administration. It's a long chapter, so this is subchapter 5, health facility planning. And it says, it is declared to be the public policy of this state that the general welfare and protection of the lives, health, and property of the people of this state require that all new healthcare projects be offered or developed in a manner that avoids unnecessary duplication and contains or reduces increases in the cost of delivering services, while at the same time maintaining and improving the quality of and access to healthcare services and promoting rational allocation of healthcare resources in the state, and that the need, cost, type, level, quality, and feasibility of providing any new healthcare project be subject to review and assessment prior to any offering or development.
So is this the criteria essentially that the Green Mountain Care Board uses when making?
That's further down.
Okay,
Whoa, oh, it's your email.
yeah.
I was like, what is
Did
it?
it pop up?
Yes.
Yeah.
Katie McClin sent you a message. Now everyone.
Good. So I need to understand how to have that not happen.
That's kind of why my heart jumps, because that's my nightmare, is that my private emails
Read.
appear on some public.
Read.
Luckily, it was just Katie. It's not like me being like, is that bill done yet?
No, but I'm just going to close this application so it does not hopefully spin. I thought I was doing that in the way that you're supposed to, so that. Okay. Based on your email.
Yes.
Based on your email, yes.
Mari?
It was,
All right.
could be another Mari, we don't.
All right, so that's further down, the actual criteria. This is just the policy and purpose of this subchapter.
Can I ask a question about that?
Yes.
What is rational allocation of healthcare resources? Is there any way to measure that? Is there any operation for that?
I mean, I think the certificate of need process is connected with the health resource allocation plan and the process. So I think it is looking at having healthcare services and facilities distributed in a way around the state that makes sense. I think that's what
The
that is.
intention.
Right. I think that's the intention there.
Who gets to decide, I guess, question.
I think it's the board is being put in.
So
or
you're
and the
thinking Green
board
Mountain Care Board is
and the
making.
Green Mountain Care Board, I mean, when this was first enacted, it was BISHCA, the Department of Banking, Insurance, Securities and Healthcare Administration. And I believe BISHCA also did the HRAP, the Health Resource Allocation Plan. Both of those have been moved to the board.
Brian,
It says in the repealed part, added 79. Does that mean that this area of law was probably created in 1979?
Yes, it's actually, it could really be the line below, but yes, this statute was initially added in 1979 and has been amended since then. In a number of different ways.
Is this taken into account when other permitting processes are underway? Like when they're an Act 250 review, do they look at if the development of as it says there, may be developed, so the development isn't happening in a way that's going to increase, reduce cost of delivery and increase quality of an access?
I am not particularly familiar with the Act 250 process, but I imagine that is not part of their scope. I think they have a different focus that they're supposed to be reviewing that is not focused on the healthcare quality access cost side.
Where I'm getting at with that is like what I said earlier about embedding them in neighborhoods. Like when we're developing these new neighborhoods, are people even going to be thinking about how do we embed healthcare facilities and healthy facilities that promote healthy behavior into those neighborhoods? If not, we have an opportunity here to influence that this year because we're in the process of land use planning. I'm just putting it out there that there might be a way to if the intent here is to, if the intent of changing certificate of need is actually that what's before us, we could probably do what's before us there, the policy and purpose, more than just changing the barriers of anyway. 79, thank you. That was my question. It just sent me off on a trip though. No.
All right, so we have a number of definitions that I think largely we're not going to look at. But I want to take you into some of the rest of the subchapter because I think it's helpful. So it directs the Green Mountain Care Board to exercise such duties and powers as necessary for implementation of the Certificate of Need program and to issue or deny certificates of need and administer the program, adopt rules, which I believe they have done, and consult with hospitals, other healthcare facilities, professional associations and societies, Secretary of Human Services, Office of Healthcare Advocate, and other interested parties in matters of policy affecting the administration of the subchapter.
Alan?
Will this mean new hires for the Green Mountain Care Board?
This is existing law.
It's existing law.
This is all on what I'm showing you right now is all existing law. The Certificate of Need program has been in effect and administered since
But
1979.
if we pass this, there'll be more criteria and things for the Green Mountain Care Board to do.
There will be fewer, I think if you pass this language, there will be fewer Certificate of Need applications because there will be fewer facilities or projects that require Certificate of Need. So I think it would go the other direction.
Okay.
I think
I
when
don't think it would reduce their.
the chair of the Green Mountain Care Board testified, I think he indicated that this was a labor-intensive process for them and that it was their hope that they could alleviate some of their burden. I think he probably said it in a better way, but
All right, then we get into the section that is largely what we're amending in the bill. So this is about, the thresholds that trigger a Certificate of Need requirement. The language you've been hearing about includes is here both for healthcare facilities and other than hospitals and for hospitals. So it says a healthcare facility other than a hospital shall not develop or have developed on its behalf a new healthcare project without issuance of a Certificate of Need by the board. And a Certificate of Need includes, and includes does mean including, but includes, but is not limited to, this list of criteria. So some of them are financial, some of them, monetary thresholds, some of them are changes in numbers of licensed beds, offering of home health service. There's sort of a long-term moratorium on new home health services. But transfer or conveyance of more than 50% ownership interest in a healthcare facility other than a hospital or nursing home. The equipment that we have looked at, the healthcare service or technology with annual operating expense above a threshold, and construction, development, purchase, lease, or other establishment of an ambulatory surgical center. For the hospitals, you've got different monetary thresholds on construction, purchase of equipment, offering of services or technologies, and change in the number of beds, and the offering of any home health service. We have the conceptual development phase Certificate of Need that we've looked at in the context of the bill. I'm mostly looking to show you things that are not specifically addressed in the bill. So subsection D is saying if an applicant is or would-be applicant is separating their project up into different parts in order to try to skirt those monetary thresholds, and it really belongs as part of one project, then they have to get a Certificate of Need. So you can't break your project up into illogical segments in order to avoid Certificate of Need jurisdiction, and the board can periodically adjust the monetary thresholds. All right, here's the exclusions piece that the chair was asking about, and then we get into the actual, what does the board look at? So excluded from this subchapter are offices of physicians, dentists, or other practitioners of the healing arts, meaning the physical places that are occupied by those providers on a regular basis in which they perform the range of diagnostic and treatment services, usually performed by such providers on an outpatient basis, unless they are subject to review under A4, which is purchase, lease, or other comparable if they're buying expensive equipment. Also excluded are community, mental health, or developmental disability center healthcare projects proposed by a designated agency and supervised by the Commissioner of Mental Health or the Commissioner of Dale, or both, depending on the circumstances and subject matter of the project, provided the appropriate commissioner or commissioners make a written approval of the proposed healthcare project. And the designated agency must submit a copy of the approval with a letter of intent to the board.
so just for my own, and I see you, Brian.
Yeah.
But for my own clarification, essentially, if it's a community mental health, then it doesn't need that.
This is like if it's by a designated agency.
Yeah,
So
by
it's
the,
specific to a designated agency doing a project that's being supervised by Department of Mental Health or Dale. and the commissioner of mental health or Dale.
But that's why, like the Brattleboro Retreat or Southwest Medical Center, that's why they have to have for mental health, because they are not a
They
community.
do not
Okay.
fall
They do
under
not
this
fall.
subsection.
Okay. Brian?
Two questions, and maybe it's coming up and I should wait, but, because I read that at first, that when I saw the part about, well, I'm glad you just rewinded a little, because it does help, because I was, as I was reading those two sections, I was trying to understand if, question one, if the state proposes it, like a state facility, does it have to go through CON? It sounds like if it's a project proposed by a designated agency supervised by the state, it doesn't, but if the state itself wants to build a facility, does it CON?
I believe currently it does. I think that's why there's a provision in the bill you've been looking at, H-96, that would say it doesn't, that would create.
That is part of the bill, okay, cool, all right.
That is part of this bill.
And the second question is, this reminds me of like on the floor of the House when it was like, is a cup of ag debate, but like, is a healthcare project that is supportive housing a healthcare project? Like if a designated agency, for example, proposed developing housing for their clients in which they were delivering services, is that a healthcare project or is it?
This is the definition of new healthcare project in 9434. So it has to be having something to do with a healthcare facility with a particular level of capital expenditure, change in number of licensed beds, offering of home health service or transferring interest in the healthcare facility, purchase of
Beds.
so. Well, I mean, in that particular one, it's a change in the number from one licensing period to the next. So I think that the short answer is no. It's a fairly narrow definition that is tied to healthcare facilities.
Like nursing homes wouldn't count?
Well, if it's
Nursing homes
15
too.
million.
Yeah, that's what I'm getting at.
Okay,
So housing where there's a certain level of healthcare services provided would qualify, but there might be a threshold where the services provided aren't enough for it to qualify as a healthcare facility.
maybe it's helpful to look at healthcare facility. There's a definition of healthcare facility.
Thank you. All
In this
right.
chapter.
That's
All
like-
persons or institutions, including mobile facilities, whether public or private, proprietary or not-for-profit, that offer diagnosis, treatment, inpatient or ambulatory care to two or more unrelated persons and the buildings in which those services are offered. Does not apply to any institution operated by religious groups relying solely on spiritual means through prayer for healing, but shall include hospitals, including general hospitals, mental hospitals, chronic disease facilities, birthing centers, maternity hospitals, and psychiatric facilities, including any hospital conducted, maintained, or operated by the state of Vermont or its subdivisions or a duly authorized agency thereof, and nursing homes, health maintenance organizations, home health agencies, outpatient diagnostic or therapy programs, kidney disease treatment centers, mental health agencies or centers, diagnostic imaging facilities, independent diagnostic laboratories, cardiac catheterization laboratories, radiation therapy facilities, or any inpatient or ambulatory surgical, diagnostic, or treatment center. So that's a facility.
Like your clinic, like housing clinic within.
Well, what's a chronic disease facility? I'm writing it down. Yeah, I'm writing down. I don't know what it is. What is a chronic
Some of
disease?
this may have evolved over time. Others.
Like-
Wouldn't the chronic disease, wouldn't it be like dialysis?
Or like, what if the federal government decides that being queer is a chronic disease and they want to build facilities for us? Like, would that, I don't know what a chronic disease facility is.
Does anyone have interest
That could happen.
in changing our definition of a healthcare facility?
To what?
Changing it, just a general question. Does anyone have any interest?
Discussing changing it? Yes.
And you do.
Sure.
I do.
What a
Why not have a
healthcare facility
discussion?
is.
Yeah, I would love to look at supportive housing and how we can promote that, like, because like if agencies want to create housing for their clients where they're providing health services, is there a way we can make it easier for them to do it, I guess?
I'm not sure putting that into the certificate of need chapter is going to make that easier.
And that's opening up a whole,
Yeah, you are.
that's like another bill involving other committees, other jurisdictions, and it's just,
But I do think what you're hearing from the proponents of the bill is they would like to make it easier to pursue these projects and not have to go through the certificate of need process. If you add new types of entities to the scope of the certificate of need process, you'll make it more difficult to develop those.
So you would.
That is not your intent.
Supportive housing would have to go through now certificate of need.
So if anything, we would want to take people off of this list.
If,
Do you-
If we wanted to make it easier, or leave the list alone and do something different.
or we could leave this list alone and either introduce another bill, possibly to change it at
Yeah, I
other
don't
points.
wanna,
You can deal
I
with
think
it.
we need to move this along and get to our other bills that we need to get done by crossover and not add a whole bunch of other stuff that we need to take testimony on and just, I think your concerns and your ideas are valid, but I don't think this is the place or the time for it.
I mean, this is committee discussion, so we're discussing, right?
Well, I think it's,
Yeah,
I
we're
mean,
discussing.
I think we all have a different definition of what a healthcare facility is. Or could be. Or could be.
Like, or what are even some of the.
Previous
Exactly.
legislators have found that this is what they've decided it is. And, you know, if at some point, I will say that, from my vantage point, I am not inclined to mess with other sections currently in statute while we're doing this, but I certainly would be open to discussing it in the future if we want to take a look at. I hate to bring this up to our legislative council, but is this in, what chapter are we?
221.
Or what, which is the one that has been rewritten?
Oh, no, that's in Title 8. We're in
Title
Title 18.
Oh, okay. I was gonna say, maybe we can discuss it when when we start going through the walkthrough on that.
I'm in favor of getting, just listening and being sure that we comprehend what existing law is, and so we can actually get
Yeah.
to the bill and sort of wrap our arms around who we have heard from so far, and then I want to go through my list of things that I picked up on from the recommendations from our witnesses that we've had, and just get to that today, so that we're not here till 7.
All right. Thank you. Thank you, Daisy.
Shall I go back into the exclusions? So, whoops, too far. All right, so in the exclusions, we looked at offices of physicians, dentists, and other providers, community mental health or developmental disability center healthcare projects. Also, the provisions of subsection A, so this is the carve out of the carve out, this is a little confusing. The provisions of subsection A that say we're excluding all of these providers' offices shall not apply to offices owned, operated, or leased by a hospital or its subsidiary, parent, or holding company, outpatient diagnostic or therapy programs, kidney disease treatment centers, independent diagnostic laboratories, cardiac catheterization laboratories, radiation therapy facilities, ambulatory surgical centers, and diagnostic imaging facilities and similar facilities owned or operated by a physician, dentist, or other practitioner of the healing arts. So this is the exception to the exception.
So this means that, like, if we go back to the top, right there. So if you are a physician's office, you are excluded from the CON. However, if you then decide you're going to offer cardiac catheterization in your office, which for the record, I know that's not gonna happen, but then you now are re-subject to CON.
Yes, I mean, I think what it's really trying to say is we're not talking about individual providers, your primary care provider's office,
Mhm.
unless it's part of a, unless it's owned or operated or leased by a hospital. But your independent provider's office is not subject to the CON process unless they are doing one of these types of functions in their facility. So it's sort of not a way to get out of CON jurisdiction. Also excluded from this chapter, subchapters, now we're back into the who's not subject to CON, are redesignations, designation revocations, and collaborative agreements of home health agencies subject to DALE supervision. I'm not really gonna get into this one because it's PACE and we no longer have this, we no longer have the PACE program. As I understand it, so.
And it's gone.
Yes, okay, thank you. Also excluded from this subchapter are routine replacements of non-medical equipment and fixtures, including furnaces, boilers, refrigeration units, kitchen equipment, heating and cooling units, and similar items. These replacements purchased by a hospital have to be included in the hospital budget, may be reviewed as part of the budget review, hospital budget review, but they don't need a certificate of need. With the approval of the Commissioner of Health, excluded from this subchapter is a facility in which the prescription, distribution, or administration of medication for opioid use disorder is a principal activity. And excluded from this subchapter, which is just added last year, are overdose prevention centers established and operated in accordance with section 4256 of this title. So that's our current list of exemptions or exclusions.
Are pharmacies in there?
Just
No,
opioids.
but I believe they are not considered a health, I don't think they fit under the healthcare facility definition.
Even though a pharmacist performs healing arts?
Because there was a vague statement about the healing arts.
It's my understanding that that pharmacies are not, I guess I'm not aware, I'll look to the healthcare advocate. I don't think they are, I mean, they're required to be licensed. There is a whole process for licensing a drug outlet under the pharmacy statutes. So they're not unregulated, they're not
They're just considered to be.
subject to a certificate of need requirement.
Right.
Was there language about other kinds of substance use treatment disorder in there besides opioid use disorder being treated with medications?
Not from I mean, there is the overdose prevention centers, but no, for
No
the,
other exclusions, though.
facility in which the prescription distribution or administration of medication is specific to opioid use disorder.
So if someone wanted to build a facility, a residential facility to treat substance use disorder, but prescription distribution, administration of medication wasn't the principal activity, then it might not be excluded.
It might not be excluded. I think that's accurate. I think that
Okay.
I could fall, depending on the monetary thresholds or the inclusive language giving the Green Mountain Care Board jurisdiction, it could be subject.
The only reason I ask is because we do need more treatment facilities of a wide variety. And if there was, maybe it's not this bill, but it would be good for us to look at ways to reduce barriers to creating treatment. That's all.
All right, then we get to the criteria. So this is how the Green Mountain Care Board review, what they're supposed to review for a certificate of need. Certificate of need shall be granted if the applicant demonstrates that the project serves the public good and the board finds the proposed project aligns with statewide healthcare reform goals and principles because the project takes into consideration healthcare payment and delivery system reform initiatives, addresses current and future community needs in a manner that balances statewide needs, if applicable, and is consistent with the appropriate allocation of healthcare resources, including appropriate utilization of services as identified in the HRAP, the Health Resource Allocation Plan. So that's one. Number two, if the board finds the cost of the project is reasonable because each of the following conditions is met. The applicant's financial condition will sustain any financial burden likely to result from completion of the project. The project will not result in an undue increase in the costs of medical care or an undue impact on the affordability of medical care for consumers. In making a finding under this subdivision, the board shall consider and weigh relevant factors, including the financial implications of the project on hospitals and other clinical settings, including the impact on their services, expenditures, and charges, and whether the impact on services, expenditures, and charges is outweighed by the benefit of the project to the public. Also, as part of this reasonable costs, less expensive alternatives do not exist, would be unsatisfactory, or are not feasible or appropriate. And if applicable, the applicant has incorporated appropriate energy efficiency measures. Board also must find there is an identifiable existing or reasonably anticipated need for the proposed project that is appropriate for the applicant to provide. The project will improve the quality of healthcare in the state or provide greater access to healthcare for Vermont's residents, or both. The project will not have an undue adverse impact on any other existing services provided by the applicant. The applicant has adequately considered the availability of affordable, accessible transportation services to the facility, if applicable. If the application is for the purchase or lease of new healthcare information technology, it conforms to the health information technology plan established pursuant to statute. And the project will support equal access to appropriate mental health care that meets standards of quality, access, and affordability equivalent to other components of healthcare as part of an integrated holistic system of care as appropriate. And then there's additional provisions. If there are competing applications, there's opportunity for interested parties to intervene. The Office of the Healthcare Advocate and the Long-Term Care Ombudsman can have a role depending on the type of facility. So there's a lot more in here, the procedures for applying. I don't know how much of it you want to go through, so I'll just tell you it's here.
That's all right. Thank you for going through it. I just wanted to make sure that, we're considering if we're considering like raising the monetary thresholds, that we understand who will be impacted above that and how they're impacted, but then who would no longer be impacted by that. I guess that's what I was saying. Alan?
Well said. Oh, thank you.
Okay. Thanks for the history of CON and for the deep dive into it. Mari.
So I wanted to bring up the issue of the word includes, which I pulled it. And I could tell you the page number, I'm sure you know where it is.
I don't, so.
So in the bill itself,
Two.
yeah, it's on page 2 and then it's repeated again on page 3. So page 2,
Line 4.
that. And then the same thing for hospitals.
So the concern was that,
We're on your
page 2, line
what?
4, 2, line 4, page 96, page 2, line 4.
Yeah.
And the word includes, as interpreted in the past by the Green Mountain Care Board, permitted them because includes. I'm going to rely on Jen actually to explain the legal part of this, but it meant that practically speaking, the Green Mountain Care Board could say any project needed to go through this certificate of need process because of that word includes.
That's right, includes, I believe it's 1 VSA section 145 says includes means including, but or includes, but is not limited to. So for purposes of the language in the statute, a new healthcare project includes, but is not limited to the following. And so I believe the board does have the ability to assert jurisdiction for something that does not meet the monetary thresholds. The existing law does not preclude that.
We'd like to remove that from the bill.
Can we go back for a second?
And what would we replace it with?
Yeah, and I just need help with something, just the language you just said, if I may just clarify. So you're saying that a new health care project includes, but not limited to, and then you said something about the monetary threshold, so if something came in at $5 million, they could decide to review it. Is that what you're saying?
You mean under the proposed
Yeah, under this language.
expanded? I mean, I read the language as not being exclusive of projects that do not meet these criteria, whether they could assert jurisdiction over something that otherwise exactly matched, but had a lower monetary threshold. I mean, I think arguably, yes.
So anything that would
Anything,
be outside of these specific criteria, the 6 thresholds that are listed here, they've interpreted it as they have the legal authority to include other projects that don't necessarily meet those 6 threshold criteria.
Is there,
And I think that is a reasonable reading of the language as it is in statute.
is there some sort of language that we could, I don't want to use the word include, but that we could add that would make it clear that these are the criteria. However, in limited circumstances, they could.
We even want to open that door.
We could assert
I think we want-
jurisdiction. I mean, yes, I think you could. I think you could say means the following, have the list of 6, and then say in addition, if the board finds whatever criteria you want to specify exists, it may require a certificate of need or may assert jurisdiction, but I think you'd want to, I think you'd want to check in with the board,
Yeah.
their counsel.
I think what I was thinking along those lines is what a healthcare advocate was concerned about, which was, I know he tried to protect the bad actor, but it sticks in my mind. Do we want to get rid of includes, and just make it these exact same things? So therefore, then the board would have no authority over something underneath the thresholds
That we would want them to.
that we might want them to say, whoa, 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 hold up for a second. And is there some way that we could include, and I think Jen just said at the end, we could say, but also that we could give them limited authority to be able to make a determination based upon some sort of criteria that, wait, we'd like you to go through CON.
Right, I think it would need to be, fairly clear so that they know how to implement it, and so that potential, developers of projects have notice of it, whether they need to get a certificate of need or not. It may affect whether somebody moves forward with a project, and if that's not predictable for them, then we may not be giving sufficient guidance in the statute.
Leslie?
I would feel more comfortable with that rather than saying it's only these 6 because, we did the stem cell bill. And let's say some, like we say, and we don't want to call it whatever. I want us to be protected. It's about protecting consumers.
Yes.
And the protection comes from the Green Care Board and from this process. So I would not want to eliminate that.
So, anyone else have thoughts on that? Mari? Yeah.
I can go along with that. It's just, I agree, we'll need to hear from the Green Mountain Care Board, and it's tricky because what are the criteria? Are there things that we can't even imagine?
That's right now.
What's gonna be on that? How do we decide what's on that list?
And then for me, it means like, I don't think we should have a list in some ways. I mean, I'm okay with the 6.
Yeah.
But that we also allow them the freedom for something to come up that someone says, well.
We have-
say, well,
we have-
But I think you can't make that just unfettered, and if the board decides it wants to do it on
because they-
another project, it can. I mean, that's not
So there would have to
giving
be
sufficient
language.
notice of what
Or
the law
maybe
is.
something that appears not to protect the public, or and I don't know, that obviously.
That would be a good,
Yes, I mean, I think you are probably inviting litigation unless you are quite clear about the additional circumstances.
How could we make it clear, John?
yeah.
I think we'd have to think about it. I think we'd want to talk to the board to understand the circumstances under which they think it would be appropriate. I don't know what they see in the way of projects or applications for projects.
Can I include somebody around the room that's sitting around the room?
Only a friend.
Um,
Well, it's,
this is sort of your concern, Mike Fisher. This is sort of one of your concerns as in your role of advocating for the health of ours. Is there some sort of language that you would think that would broadly cover to protect?
I heard Jen going in a direction that made sense to me, that here are the lists. That the board may, however, based on this factor and that fact, like lay out very clearly what
Mhm.
factors would lead to the board having, evidence-based medicine, I'm not sure exactly what else, but that we would need, that we want to lay out really specifically what kinds of dynamics we would want to allow the board to assert jurisdiction other than the first 6 factors.
Like evidence-based medicine, that would go with our
Yeah.
stem cell, probably. Mari,
And maybe it would fall under
Sorry, Mike Fisher, healthcare, sorry.
the first part of the certificate of need process, like the jurisdictional part, or the next part, which is in this bill, which would be the expedited, or not the expedited, what's in the first part of this bill. So the criteria we're thinking of wouldn't have to go through the whole certificate of need.
jurisdictional. Is there something in statute around the jurisdictional, or is that in rule with?
I think it's how they implement it. I don't think there's, I think that may be in rule as far as how the board operationalizes what's in here. I don't think there's anything about like a jurisdictional determination or something. Is that what you're,
Yeah, so that's in rule. That's
I
not,
don't think,
It's some other
No.
way other than for the Green Mountain Care Board to have authority.
I think somebody files a letter of intent to seek or to establish a project. But I don't know enough about how the process actually plays out. I don't know if the healthcare advocate does.
I think that, I'm gonna reach out to the Green Mountain, to the board and get their feedback on this. Is that all right with everyone?
Yeah.
Yes.
I would love to see, like, is there an application? You might know, there's an initial application?
Yes.
That's on mine. You can find that on the Green Mountain Care Board website. For the
Oh, okay.
certificate of need.
First, there's a jurisdictional application
Mm-hmm.
and which allows the board to receive enough information to determine whether or not you have to go through the CON process or if you're exempt from the CON process. Am I right?
And that's not changing.
And that's not changing.
Right, so there's a letter of intent. Prior to filing an application for certificate of need, an applicant files an adequate letter of intent, but that's before filing. I think the question is whether somebody knows that they need to file or not. That's what we're talking about. I guess applicants who agree their proposals are subject to jurisdiction under these criteria do not have to file a letter of intent and may file an application without further process. So I'm just trying to track what's in here.
So is there something we could put in language that essentially says that unless you are exempt for all the reasons you told us you're exempt, then a letter of intent needs to be submitted to the board. And then the board will make the determination whether or not, which I think is what they do right now, you have to give them certain pieces of information. And then they determine whether or not you need to go through the CON process or not. And at that point, could we have something that gives them the authority to say, yes, it doesn't meet these 6 criteria. However, they could require that process for
I mean, I think it's at the outset, it's about somebody knowing whether they have to file a letter of intent. And so if, and I don't know when people are looking at creating projects now, whether they mainly look at the monetary thresholds to determine if they need to check in with the board. I mean, I don't have a sense for how it works in practice. That somebody says, oh, before I do this project, I need to check in with the board in some way. And so how do we put those people on notice that they would need to check in with the board? Find out if they're subject to jurisdiction. I don't know if you want.
would Health First like to?
Well, my understanding is Susan Richardson.
Yeah.
That the people who aren't the bad actors, so we're already in the system, they know about the jurisdictional letter, it's the quote, whatever bad actors that probably wouldn't know, who may not do it anyway, they don't.
They still would have to go through licensing, correct? I mean, we have
Depends on-
other
Depends on the type
areas.
of, yes, depending on the type of, you know, I mean, it would have to fall under one of our licensure
This Department of Health.
statutes. Right, I mean, the Department of Health licenses hospitals and ambulatory surgical centers, the Department of Disabilities, Aging and Independent Living licenses nursing homes and other long-term care facilities. I don't know how some of these other, you know, if somebody was creating a freestanding center of some sort, for example, you know, it's not clear that they would be getting licensed unless we had licensure statutes that required them to get licensed.
I think that if anyone from the board is listening and here's our concerns and maybe offer us, collate our thoughts into something that they could send us, that would be great. Does that sound good?
I think you have an idea, son. That's good, but that's to get them to come here. Like you mentioned before.
And I can reach out to the board
And
to
help us.
spark some conversation because
Yeah.
I'm, you know, I'm looking for their input certainly on what those criteria might.
So they're licensed. When does the licensing practice, when does that get applied? After they file? I was trying to look at it, I couldn't figure that part out. Because wouldn't the licensing process also weed out what we're calling bad actors? Would that? It would not?
Not all the time.
Necessarily.
I mean, licensure is an affirmative. You reach out to the licensing agency and say, I would like a license. So if somebody does not reach out to the licensing agency, I mean, there would have to be a complaint or some other awareness brought to the licensing agency that somebody was operating a facility without a license.
Okay.
Is everyone in agreement over the general premise of trying to filter out people who may not meet the monetary thresholds, but still might need some additional
Oversight and regulation.
Yeah.
Just attention.
or attention? Is everybody in agreement of that general concept?
Yes.
I mean, I will say, I'm not sure that's functionally all that different from the situation right now.
Yeah.
Where it specifies these 6 and says it includes, and there may be others. And I think,
So we may not have to do
That's-
anything at all.
well, right, I'm not sure I think we may be tying ourselves in knots over something that isn't actually a change from the existing practice.
Thank you. Let's
We could,
not.
So if there are specific types of facilities you would like to exclude, we can affirmatively exclude them.
If I may, yeah, the change is from 1.5 million to 10 million. And that's a big change and the 1.5 is a pretty low threshold, so that would exclude a lot of people. Whereas
Right.
that between that and the 10 million might include, like, because the birth center thing was about 5 million, I think, or 4, somewhere in there. That's.
No, you're right, because I do think there is some inconsistency in saying, here are our high monetary thresholds. But then the board comes in for somebody who's lower than that if we haven't it may be what happens now, but if we haven't previewed that possibility, but I think from a practical standpoint, the result may not be different from now, but I think maybe it does make sense to structure it the way we've been talking about.
Are there any exclusions anyone wants to talk about, or do we want to move on to the monetary thresholds?
You mentioned evidence-based and, I don't know who applies that. It's a little bit of a mystery to me, but.
I think I'm gonna seek input from board.
Yeah.
I think that they probably and then work with our legislative council and, see if we can come up with something to coalesce our thoughts around this and if that can be achieved and how best to achieve that. And then have them bring that back to us.
I think I would
Is that-
appreciate that, because there are concerns
Yeah.
from other advocates and groups that are concerned about that.
Yeah, and welcome input from any advocates or groups. So, all right, so should we move on to the monetary thresholds? We heard this bill started at 10 million for all pieces. And we heard testimony from the board and others regarding changing some of them. Does anyone have strong thoughts about the dollars?
Weren't all of the witnesses pretty much aligned in accepting the recommended changes by the board, the changes that the board recommended?
I
Believe so, yep.
I believe so.
3, 5, and 10.
Yeah.
Yeah. So is everyone in agreement of changing those thresholds to 10, 5, and 3?
Yes.
Yeah.
And then there's a 50,000 too.
If it's a big project.
Mhm.
Just as it's also there.
Hospital project that increased from 30 million to 50 million, I believe. Conceptual. And I don't believe anyone made any recommendations to change that, and everyone was in agreement with that, correct? Yeah.
No, that's okay. I'm gonna need you to be, people to be a little bit clearer about what you want as different numbers in different places.
So page 2, line 8,
Yeah, so
keep that at 10.
let me put this up on the screen so we can all be looking at the same thing. All right, page 2, line 8.
Everyone was in agreement at 10.
Okay,
It's a reasonable amount. Page 2, line 17. It was 10, but 5 million.
It says 10 in here. Did we just lower that?
That's the one that the board recommended be lowered from 10 million to 5 million, and I believe everyone was in agreement with that. And then page 3, line 6 was from 10 million to 3 million.
okay. Great. And
And then all other ones,
then page 3, line 12 stays at 10 million.
I believe that, so this is for,
Ambulatory Surgical Center.
yes.
Okay.
These all remain at 10,
Okay, and then for the hospital, 10.
hospital 10,
Okay.
and then page 4,
For
line 21, everyone.
Line 1.
Oh, yeah, 10.
10, okay. Just get these checks.
Yeah, 10.
I feel like Austin Powers.
Okay, line 11.
11,
Line 11, $10 million. That stays. Oh, I'm sorry. Yes, would you?
I believe the board was recommending 10.53 for hospital and non-hospital. There's no difference between the two.
I thought the board was recommending for hospital that it was 10, 10, 10.
And I did reach out to Representative Lanford, for clarification, and I shared your corrections to my threshold spreadsheet, with her. So I'll share it with you when I get the
Okay,
board's response.
okay.
Yeah, the
Thank you.
communications I've had with them, it was definitely not different.
That it would be the same.
Of that, yeah.
I'll pull up the care board testimony.
You know what? I'm sorry. I just had crossed off the first. I think you're right that they recommended aligning all of them.
Okay. So going on.
well, let's just get what the written
Right,
recommendation.
so
Yeah, we'll get the written.
So 10, still on page, where are we? 3, line 19. And then top of page 4 would be 5.
5.
Okay. And then on line 11 would be 3.
Yes.
3. And then
Line 21 remains at
50,
50.
okay. And then.
And we'll cross-check all these, right?
And then,
13.
13 is okay. 13 is just,
Good.
I think is just aligning with the change on the previous page. But line 17 says 10 million for both.
I do not recall if there was any change to that. Does anyone have, I'm sorry, I'm trying to go back and I'm looking at.
I can't find it.
Presentation that we were given.
This is line 17, page 5.
Yes.
I have both from Susan Rigson's spreadsheet in mind that it's both 10 million.
Okay.
Agreed.
Okay,
And then, let's see, where are we?
for numbers,
It's different numbers, and then there were different exclusions between different bills.
yeah. So do we want to talk about exclusions? So the recommendations were that we took 2 exclusions that are actually currently in S10.
Yep.
One is around excluding depreciation. So in other words, you know, you have an MRI machine and it breaks or you need a new one, that you don't have to go through a certificate of need to get a new one.
Right, if it is fully depreciated.
And then the other one was around the emergency, non-emergency ground transport, EMS. So you don't have to, is everyone in agreement with
Yes.
moving those maybe from S10 and putting them into this bill?
Yes.
And so currently in here, we have the healthcare services for construction, development, purchase, renovation of a health facility, which is an award of the contract awarded by the state. So in other words, if the state deems it necessary, has come to the legislature, they've appropriated the money, that they don't need to go through a certificate of need. And I will say, full disclosure, that I had AHS reach out to me, and I think that they may want to change a word or two in this, and just, I think they wanted to talk about it a little bit more, but that they might have a tiny language change. And so I asked them to please send that too.
I still need to be convinced
Convince
Do you,
that I can support this exclusion.
okay? Do you wanna, do you need to, who do you need to hear from? Because we can certainly,
I need to understand the implications, the operations of that. I understand the theory of it, but I don't understand how it might work. If the state wanted to do a project and how it might impact something. Without going through the CLN process.
can I ask from the sidelines?
Sure. Devin Green, Vermont Association of Hospitals and Health Systems. So if the state wanted to do a project and there was funding allocated through budget process and through the legislature, they could then have a contract with that healthcare organization. The organization could then start building and start the project, as we've seen with the Southwestern Vermont Medical Center project. It's been over a year with the CON process now, and that has gone up $1 million due to delayed construction costs. And so it could save a lot of time and money.
No, I understand that, but if we have this bill, then that doesn't apply.
It wouldn't apply to that, but it would apply to future.
Right, but
Initiatives.
but still it would be under 10 million, it wouldn't apply if it was over 10 million, then maybe it needs to be looked at.
No,
I think this would exempt, if it was over 10 million, this would exempt it by virtue of being a state.
Yeah, and that's what I'm struggling with, exactly.
It would go through the whole, I mean, it has gone through a process of the legislature, the whole state saying this is a needed. This is a needed service. And so it's already been determined that the state needs this.
I get that. The state need it, but what about the community? What about, other factors?
would the healthcare advocate like to?
Mike Fisher, healthcare advocate. To one thing the hospital association just said, we think the example of the SVMC application has taken too long, shouldn't take that long. Agree with you there. But I think if you listen to yesterday, 2 days ago's testimony, which I haven't, but I had a team member there, you'll hear a in-depth, careful conversation, and not, and the board hasn't made a determination yet. But you'll hear a full discussion and evaluation by the board of whether the project is really warranted. And I don't know that it's a slam dunk this moment. I don't know what the board's gonna do. So the landscape changes. And the landscape has changed more because of how long it's taken, but so I do think we have an example in front of us right now. I've had members of the legislature who supported this project through its process approach me in the hall and say, what did the board do? I'm not sure we should do it. So I understand why there's a desire to exempt this. I still think it warrants review. Review, not just that it meets the needs for the policymakers that make the decision, but that it fits in the landscape of providers.
And community.
Yeah, community.
Is it, and I will call you Devin, but is, when the state sees a need within the community, and when I say community, I'm talking the state of Vermont as a one community. When the state recognizes the need for a facility or services, what have you, and then they come to the legislature and they make the case for why they need that, and the legislature does its due diligence and appropriates the funds for it. Does the Green Mountain Care Board in their CON process, they're thinking about things that we're not thinking about? Like, will it affect another institutions or facilities? I mean, they're thinking about competition. Whereas the state doesn't necessarily think about that, and neither does the legislature. We just sort of see a need. So do we need the care board? And I'm just pushing back a little bit. Do we need the care board to take into consideration things like competition when issuing a certificate of need for something that the state has deemed is a needed service?
Can you define what you mean by competition? Because
Well,
it's tricky
let's-
in
let's-
the
let's
context
say-
of
Let's
healthcare, there
just
really
keep
isn't.
using, you know, Southwestern Vermont Medical Center. If the state doesn't, and the legislature, I know that we didn't ask these questions because we were doing this. We didn't ask the question, will it affect the rates that somebody else will get, you know, at a different facility that might provide this service? We were just thinking about, does the need exist for this type of service? And are we meeting the needs of the state of Vermont and the people of the state of Vermont? We weren't thinking about what's it gonna do to the bottom line of another facility that might provide that. But the board does take that sort of thing into consideration as part of the certificate of need process. And do we want them to do that, or or is there something that we could maybe do that addresses everyone's concerns rather than having an exclusion, perhaps, I don't know, a different type of review or no? Can I ask, just because Devin wanted to chime in and then I'll go to you, Mari.
Sure. Devon Green Vermont Association of Hospitals and Health Systems. I'll just say for this example of Southwestern Vermont Medical Center, they were the only ones who responded to the RFP. It will have a really chilling effect if the CON is gonna be in place for healthcare organizations to bid on any state RFPs.
Mari.
Really torn because I do feel like we still need regulation and oversight of all projects, including contracts awarded by the state. I also hear what Boz is saying.
I got,
Yeah, I'm sorry, Ellen.
Okay. you guys had me pretty well brushed up on supporting this. I just wonder, are the Green Mountain Care Board, they're gonna do the thresholds, they're gonna do the criteria, they're gonna do the head mount, are they just gonna take over our healthcare system?
We're actually not doing the,
Well, signature.
Well, they're involved in it, they're involved in it. So I'm just wondering, we're giving a lot of authority to the Green Mountain Care Board here.
They already have.
they already have this authority.
I suppose, yeah,
We're actually pulling back.
and make it easier.
We're pulling back some of the authority that they have.
Don't seem it.
Well,
What we're trying to, what we're trying to do is give them an out to do it if they think it's an evidence-based reason for doing it. I think that's what we're trying to do.
But we're giving them the authority to do it.
no, they have the authority right now to do it. Like this right here, this excluding, we're actually diminishing their authority
By the exclusions.
by the exclusion. Mari?
No.
Daisy.
It's Friday.
I wanna-
My first committee discussion.
I don't think I know I didn't understand the point that Devin and I think Mari also made about the state bidding on things. Can you clarify that for me?
This project was, the state put out an RFP saying there's a need for inpatient adolescent mental health care. There was one bid on that RFP. The state looked at that bid, they approved the bid. They haven't awarded the contract yet because there's been no certificate of need.
I see, and it's in the southern part of the state where we don't necessarily need another facility of this type.
But also there's no inpatient psychiatric care, adolescent psychiatric care, like.
Psychiatric medical.
Psychiatric medical, that's right.
That's what's
Thank you.
important about it.
That's
Got it.
the piece that the state saw the need for, was having the medical component,
That's right.
because for people with comorbidities.
Right.
But
But what is, I don't understand how it relates to this specific carving out of the state not having review?
Because the implication of the state putting out a bid is that you get the contract and you can start the project. With this,
Okay, got it.
you can't start the project because you have to go through, even though you went through the legislative process, you have to go through a whole other process.
But if the money goes. Okay, my next question, or just, I guess, point is, as we're making any changes, aren't we always striving to create a more equitable system? And I think I'm contemplating how we do that if we're measuring people by different sticks, right? And I think it's a stick by which the care board is measuring, like we just looked through the statute, you know, the measures by which they're looking at whether a facility is needed would be different than that by which a changing administration and changing legislature looks at the need for a facility. That's what's kind of in my head around carving anybody out from a care board review, and including, you know, the designated agencies, which are not part of it, sorry.
No, I was gonna ask Devin, also to your point, though, I think what you were trying to say is that the very existence of a CON process makes it so that when the state puts out an RFP, everyone just says,
Heck, no. not
no
gonna do
way,
that.
I'm not gonna do it, because I know I'm gonna have to go through years of CON process. And how much does that cost? Because I'm sure that the state is not paying for that process for the CON. It's probably Southwest, which ultimately the taxpayers are paying because we have to fund it. So I'm gonna let Mari and then Leslie.
And the way this current draft is with the thresholds, Southwestern would still have to go through the CON process.
Would they, what was
It
it?
wouldn't have had, it was at 9 million originally, but now it is at 10 million. So it would have to go through net.
The CON process put them above the thresholds that were considered. Leslie?
But I think that's the point, is that most of the projects are gonna come in under $10 million of the state, at the state, unless they're doing some giant $50 million project. But I mean, it seems to me that the state and the Green Mountain Care Board have different objects. The state object is to do their due diligence and fulfill that need. I'm not necessarily sure it's looking at community as a whole. I'm not an advocate of competition as a way of driving this, but that's a conversation from another time. I think the Green Mountain Care Board looks at it from a different set of lenses. And I don't want to lose those lenses on state projects.
What lens does the legislature look at it through?
The legislature, I think, well, from my time here, this is my cynical self, is a little bit doing what we're told. Because we don't have staff and we don't have an opportunity for due diligence. We have you, which I appreciate, thoroughly, and you too, but we don't do it ourselves. You know, we don't have that. And in a way, I think it's a matter of faith that we, as a legislature, believes the state is going to operate in a certain way, as opposed to the Green Mountain Care Board, which is going to operate in a different way.
Well, can I open a can of worms?
You mean more worms?
Would some of the healthcare advocates' suggestions around I'm so sorry. It like literally was in my head and then it just left my head. Timing. Thank you. Would some of the healthcare advocates' suggestions around timing the CON process, because we haven't even talked about that. Do we think maybe that might alleviate?
And remind me what those are, just so I have it top of mind.
I think that must be done within.
Oh, yeah, within 6 months and
9 months, he said.
9 months, well, the tier 1 and the tier 2, I thought was,
Is anyone, and Jen, would this be the right place to discuss it if we were gonna talk about tier 1, tier 2? In regards to things that actually did trigger the CON process? Could we add in that, the board shall in the first round finish within 6 months or whatever? I think that the Health Star Advocate had proposals. Yeah, go ahead.
Mike Fisher, healthcare. I think if the committee is interested in some limitations on timing CONs, in my opinion, the right next step would be to ask for the board's guidance in appropriate way to do it. We did put some numbers on the table, but we really meant them as a sort of a concept, a starting place, and that it makes sense to have the board comment on how what's the right way to do that in a way. I think there was some discussion at the time, like if we're gonna do it, we gotta really do it, so we don't want to make it. We want it to still have some meaning. And so I think I would want to hear from the board.
We have asked the board today for a couple things, and maybe we can add that to the list, if they're listening.
In all due respect, 9 months is, that stuck in my head. I've seen a lot of projects, sometimes just don't make that timeline. And I don't want to put a stone in the road to stop it. So I guess I'd check with the Green Mountain Care Board and yourself and us and come up with a reasonable solution that would work. So.
And I'm asking them if they can come up with a reasonable solution and some guidance and maybe send that to us.
And I think what's challenging for me is that I have examples of ones that took way
Yeah,
too long.
I'm sure. Yeah, I'm sure that happens.
So what's the right sort of?
Yeah, what's the right,
Well, can we have examples of things that went well? Do they have examples?
or the right time, how about the right timeline based upon the resources that we have given them?
Yeah.
Fair.
Okay, so we're gonna table the state,
Madam Chair,
yes.
I think among those two witnesses is fine, but I think we should also bring in some people that have had it done. Some people that have been successful and some people that have been unsuccessful. So we can get their point of view too.
We did,
Oh, we did?
yeah.
Who the hell were they?
Well, we had in the Green Mountain Surgical Center that I believe they told
Oh, yeah,
us it
okay,
took like
that's-
well
I
over
thought we were
4
talking
years.
I thought we were talking about this solution. Did they tell us how much time they think it should be? I don't remember them.
None.
I think that if they had the chance, they would probably say that.
Well, they'd probably say they didn't want to.
I think they still
Right
have
now-
PTSD, so I'm not sure.
Yeah.
Well,
that-
right now, the way we have it,
You've done a good job.
it took care of that problem. That shouldn't happen again. We're talking about going forward.
Well, yes, for the thresholds.
Yeah.
But there will be projects that fall past the thresholds. And so what really is a reasonable time? And shouldn't we really get the board's opinion on the time that it will take them to
Absolutely.
actually achieve this?
I'm not at odds at all with that. I'm at odds with having two people which probably believe that they're probably gonna come in with the same answer. How close to it. I'm talking about people that have experienced it. We should be able to learn from the surgical center as an example, the Bennington thing as an example. We should be able to learn from those. What's a better way to do it? What's a better timeline?
Well, I believe we also had Rutland Regional Medical Center was in here.
Well, if you think we've had enough, that's fine.
Um,
I'll make my judgment on what they say.
I do know that we did send out an inquiry as far as parties that have gone through the process,
Right.
been unsuccessful with the process, been successful with the process,
I
took
agree.
lengths of time,
Okay, that's a part I
And-
don't agree.
and
I don't remember anybody telling us the length of time. It would have been better if that project, if that was done in 3 months. They said it was too long.
would the representative that represented the Green Mountain Surgical Center like to comment on the length of time? Okay.
Sure, David Mickenberg here on behalf of the Mountain Surgery Center. Remember, the time is not just when you're subject to CLN, the time is not just the time of the application, but it's the years of implementation reports, it's the multiple coming back when problems arise. So it really took like 7 years. The actual application process were 2 years. But our hope, and I think others, is that under a certain threshold, it's no time because there's not a process.
And that does this.
This bill, as it currently is, would do that hopefully, you know. And then above that, in terms of the time, I do think it may, you know, with projects above 10 million, or 5, 3, wherever you land. It does seem to make sense that particularly in the number of questions that can be asked from intervening parties and things like that, that there's some discussion of time if you're going to have a process above 10 million. I don't know what that is exactly. Our focus has been on trying to get smaller projects out into the community. So, but I'm certainly happy to think about it and come back with some thoughts for you.
I just did want to finish that we did reach out to a number of organizations and tried to get a read on people who had straight gone through this process. And we heard from the people that we got responses from.
The other ones didn't respond.
Yeah.
Well, when you ask for something and people don't respond, then that's tough on them.
The invitation and for anyone out there that's watching on this, that if you have thoughts on this, we'd love to hear them. Okay,
Madam Chair?
yes,
Oh, yeah. I ask a question and make a couple of comments.
sure.
Susan Rickson, on Health First. So I just want to be clear, it sounds like the thresholds for hospital and non-hospital will now be 10, 5, 3. Which, just to remind folks, you know, we could live with that, would prefer no process though, for those folks. And I'm trying to understand if there will be a process for those under those thresholds.
There will not be a process under those thresholds unless through some sort of jurisdictional process, the Green Mountain Care Board identifies for very, very limited reasons why they would want to actually get more information and force a CON process on someone. We're really now more talking about if you are above those thresholds, what would the timing look like? And also if it is a award by the state of Vermont,
Is that
Is-
automatically?
is that reason enough for exemption? And I'm hearing that there are concerns about that. So let's talk about maybe who we should talk to, or we could essentially just wipe that. If it's the consensus of the committee, we could just wipe out that exclusion.
I want to hear from the agreement.
That's
Yes,
exactly right,
yes.
yeah.
And
I think we have that.
Yes, and I did indicate that that Agency of Human Services, I believe, will be asking us to make some small changes in the language that maybe might sort of leave it. I'm not sure yet. I haven't
I mean,
seen.
they may want to testify too and comment on that, which would be great.
Okay.
And I don't know if you want.
So the state is AHS that's granting these?
Yeah, yeah.
Okay, just wondering which entity is the.
Well, because
it could be.
if it was a healthcare facility and a healthcare project, it would most likely be coming through one of the departments within the
Okay.
Agency of Human Services.
Gotcha.
Which means
Like
it also
the-
go through us and Human Services.
Yes.
Committee. Which means it also either come through here or Human Services.
Okay.
Yeah.
So we should actually probably check in with them. I don't know if that's on the plan because they might want to have some input.
And if I recall, the one that we keep referring to, the Southwest Medical Center, that went through, I think Corrections and Institutions had, not necessarily jurisdiction, but they did a review of it. Human Services did a review of it. Healthcare, I know, did. We took a couple days testimony, I feel like, on that. Appropriations, obviously, and then obviously all the pertinent Senate committees had. But, okay, so for purposes of today, I say we table that and look for some guidance from some other. Yeah, I'm sorry, you had asked a question, but then you said you had some
Comment
comments.
too. I just want to please restate that Vermont has a serious cost and access issue. Con is associated with higher costs, worse access. We have one of the most restrictive con laws. I'm happy that we're doing this work, but let's remember what we're trying to solve. Cost and access.
And quality.
Yes, and quality.
Oh, but actually, I'm gonna defer to Alan.
No, I was just pointing because she.
Oh, okay.
Devin Green from Buzz, and I, just to add on to what Susan was saying, I understand that the Green Mountain Care Board recommended the 10.35 or 10.53 thresholds. Hospitals agree with making the playing field equitable for independent providers. But we agreed to that at the $10 million amount. Having 10.53 makes it more inequitable for hospitals that tend to just have higher costs. So we would prefer the $10 million threshold, and again, advocate also for an even higher threshold for the academic medical center just due to volume and issues there.
Thank you. Of course.
I thought we had a witness, I can't remember which one it was, that talked about MRI machines and all that, and gave us a figure. And I thought.
That was Rutland
It
Regional.
was
Oh, it's 4
Rutland
million.
It
Regional.
was the depreciation issue.
Yeah. And 5 million was okay, that's what I remember.
But also that was the depreciation issue, which is being added as one of the exclusions, where if it's fully depreciated, you can replace it. You don't need to go through a CON to get it. A replacement for something you already got a CON for, and
So why,
all of that.
so my question, if that's the case, why isn't the 5 million okay? Why does it have to be 10? I mean, 10 is fine.
It doesn't have to be. It can be whatever we make it.
I know, I understand that, but we're getting information.
I know, and I will say that I feel as though we landed on numbers that we all agreed on.
Okay.
Is there anything else? So we're gonna take this back up, I think, on Thursday. And it is my hope that we will have received lots of information from all of these people who I know are watching us right now. And that Jen will have some language for us, and that we can do maybe some final markup and a possible vote on this. Is there anything else within the CON
Yeah.
world that anyone would like to talk about. I actually have one thing. Yeah.
Did we talk about closing the expiration loophole, like for price caps, accepting Medicaid? So
No. We didn't.
we
You
got a
wanna talk about that?
recommendation to do that. And then a reverse con.
Oh, yeah, that's on my list.
That was
And
my list, yeah.
I think we had two presentations at least, one by Green Mountain Care Board, one by the Healthcare Advocate, that had very clear recommendations at the end of their slide decks. And that would have been a good thing to just quickly review before we adjourn and just make sure that Green Mountain Care Board had them at the end of their slide deck, and so did the Healthcare Advocate. They made really clear recommendations. I couldn't find the Green Mountain Care
I
Board
couldn't
one.
find the Green Mountain Care Board one.
But that one I just noted about the expiration loophole. I think that one is one I'd really like to talk about. So not only, my understanding was it's something that in order to get a bond, you have to meet the requirement. I don't understand why you would ever sunset the requirements. It's like, if that's what you need for one, then you should have to maintain that level of care or whatever the requirements are. I think that's something we should consider or hear more about.
So maybe we could put those up there if you have them,
Yeah.
I don't have them up.
or we could do it the next time or something.
Yeah, maybe we can take it up next week.
Yeah, let's
take it up
Because
next
I think
week.
it's a longer conversation and we also had heard about the burden that is for providers to implement it. And I think that's the last thing we want to do.
Sure.
So I think it's a real balance, but I also thought it was a real, to your point about quality, Leslie, I think it's worthy of discussion.
Okay. So let's talk about that next time. And I wanted to briefly touch, and I wanted to get legislative counsel's opinion on this regarding the idea around the reverse CON.
Are you looking at my list?
I am, I mean, no, I mean, I have reverse CON anyways. I mean, I've only asked about it, every
Yes.
single person that's walked in here. And I'm turning to you a little bit. Now, other people could have other ideas, but in my mind, what we're trying to solve is that essential services cannot just summarily be shut down at that are needed services within the community. And I think particularly we're talking about hospitals cutting service. I'm not talking about things like there's an FQHC and they're becoming insolvent and they need to shut down. And they have to have a certificate of need to be able to shut down because that's not going to help them. But I think we're talking about things like just because your budget was decreased, you can't go and close primary care and shut down the inpatient mental health beds.
Unless you have evidence-based data that says we don't need this anymore.
Yes.
It can be
And so
arbitrary.
I'm
That's the
wondering,
point.
if it would be best to actually maybe include that somewhere rather in the hospital budget review process, where if services are going to be cut from a hospital, that those be reviewed by Green Mountain Care Board.
That only happens once a year.
That's exactly where we're going.
Well, I think you can, I mean,
No,
They do
like,
enforce-
back.
Yeah.
right, but I mean, they do enforcement throughout the year. So I think that could
Well,
be.
Could be really, yeah.
Right. I mean, again, I think I'm gonna want to hear from the Green Mountain Care Board on where that, they think that fits most, but it does, well, it's referred to as a reverse CO, and I think it is, the context you're talking about is more service reduction. That makes more sense in the context of hospital budgets, if your focus is on hospitals.
Yeah, and we also were talking about, if that is going to happen, then there needs to be a transition plan.
That would be part of what the board
Right.
would,
Right.
That might be a
Just
rule.
plan.
That could be a rule.
I mean, if you can't do it and you don't have the money to do it, okay, what's the plan?
what's the plan?
Because there's a need in the community for this. And you know it is because you've been doing it.
And we've been talking about it forever.
Easy?
I keep going with the list.
Yeah.
I assume we're gonna,
Oh, are we moving on from discussion? Did you?
unless you want
anything
to
on-
keep discussing.
No, I just wanted to throw that out on the table. Is there anybody who is opposed to something like that?
Yeah, I think we need it.
Okay. So we'll talk about where the best language around that is and where it should land. You're guys, everybody's getting
So
ready.
I want to bring up something that Mari suggested, and that was that we consider how to address projects that are currently in process. So that they don't get caught. Yeah, I thought that was a really good suggestion.
I mean, like a grandfather or
Oh,
a
grandchild, a grandchild. Let's grandchild them.
I don't know, just.
I mean, I guess I think you should probably address what you want to have happen. I mean, if it's already. I mean, I don't think you can impose a certificate of need requirement on a facility that is, or a project that is already in process, but I don't think you're talking about doing that with the direction you're going. So I don't know if the proposal is to, I mean, I would imagine you would continue through and this would just apply to to new projects. But if you wanted to do something to expedite or change the ones that are already in place, again, we could talk to the.
Or maybe the ones that are.
Typically, we have made changes.
That with these changes wouldn't even meet the thresholds.
Doesn't matter.
So,
We typically, when we've made changes to the CON statutes, I believe we have had them apply beginning with new projects. So anything that is currently in process continues under the process it's under, and anything that is new would go under the new process.
Leslie,
So it's public record, right, that they're doing this, so we'd be curious to know what in fact is out there. And that maybe we could look at, and I'm not suggesting we do it now because like spray and cook. But I think that would be a process that might have merit to see, maybe there are none in the pipeline, maybe there are 12.
You can look at the Care Board's website, they're all on there.
they're all on there.
I'm not looking, so if you want to tell me what it is, that's great.
Not that I'm putting him on the spot tonight, but can I reach out to the healthcare advocate and maybe he might know an approximate number of, do you have any idea how many?
I don't.
Sam looking at.
Sam's gonna text me in a second, and tell me. but-
Yeah.
If there's something that has been under contract, I mean, if there's a contract, right, somebody, I don't think.
How many you
there's any
see?
need
No,
for anything.
no. This is a bill. If it comes into play, we abide by the rules. If people have applied for these things and are in process, how do you start saying, oh, no, now you gotta do this?
Well, I think we can adapt it. I think I mean, I'm willing to think about it. Let's just say that. No, I don't know how.
I think you could give options to reduce requirements. I don't think you can impose new requirements on
There we go.
existing
If that's
projects.
the
Something like
case.
that, totally.
Yeah, Martin.
This is related to, and said with all respect and, care, and saying this on the record, if we could avoid using phrases like grandfather, just because it
Oh,
has
sorry.
roots in pretty racist origins. Thank you.
Say
I
that
didn't know
again.
that.
I
Say
didn't
say that again?
The term grandfathered is rooted in very racist origins, so I'm asking us not to try to remove that.
Thank you for telling us that. I did not see that. Thank you.
So what's that make me?
I'm talking about
It's
grandfather.
only a problem when it's a verb.
Yes, thank you.
So we just have to say grandparent then, right?
You don't,
No.
No, that's not.
no, I don't think it's a gender issue.
My wife-
It's a
I make a
racial
motion
issue.
to close.
Anyway,
Right, anything else? That we want to talk about?
I have one question. There was a hand up over here
Oh.
earlier.
I'm sorry.
And I don't know.
I apologize.
I don't know if you've got anything else.
It's Friday at 3 and I'm getting a little fried, so.
So, Devin Green was, before moving forward with the reverse CON, we would like a chance to weigh in on that.
All right,
6 pending.
there are 6 pending.
Need off.
Thank you.
I think that's a small. Thank you, Sam.
That's funny, because I just read
Yes.
that they only received 7 applications in 2024. Are those left over from?
Does that include like the jurisdictional, the conceptual, the actual? I think there's probably more if we pull those in.
A little more deeper information to understand where they stand. I guess it's gonna require a spreadsheet. I think there's
You're
one
gonna
or two
have to go
guys.
on and correct.
What?
Yeah, I think we're cut.
Could, reading time sheet?
Yeah, yes, okay, so clearly we need a little bit more time with this. I apologize for anyone who has to do homework over the weekend. I'm talking about people who might be viewing notes. Not you, Jen, don't worry.
Just get plans.
And let me just ask really quickly, because I don't even think I asked the question, does everyone want to move with doing something around certificate of need?
Yes.
Okay,
Yes.
all right, we have consensus on that.
Oh, yeah.
Thank you.